Dunia ini dulu aman dan damai, semua mampu tersenyum saat yang bahagia.
Bebas bersama, kemesraan terjalin, kerjasama terbina, rezeki terus melimpah.
Tiba-tiba tidak kusangka engkau yang tidak kelihatan
mampu menggoncang dunia, inilah ujian darinya. Kami terjaga, kami bersedia berjuang tanpa henti. Segala usaha dan ilmu dipertaruhkan demi untuk semua.
Semua ini telah diselindungkan, suasana berubah bagaikan mimpi. Perjuangan kami tanpa putus asa, kita pasti menang, matlamat untuk semua. Tiba-tiba tidak kusangka engkau yang tidak kelihatan mampu menggoncang dunia, inilah ujian darinya.
Kami terjaga, kami bersedia berjuang tanpa henti. Segala usaha dan ilmu dipertaruhkan demi untuk semua. Kami terjaga, kami bersedia berjuang tanpa henti. Segala usaha dan ilmu dipertaruhkan demi untuk semua.
dipertaruhkan
Demi untuk semua.
dunia ini dulu aman dan damai, semua mampu tersenyum saat yang bahagia.
Bebas bersama, kemesraan terjalin, kerjasama terbina, rezeki terus melimpah.
Tiba-tiba tidak kusangka engkau yang tidak kelihatan kian darinya. Kami terjaga, kami bersedia berjuang tanpa henti. Segala usaha dan ilmu dipertaruhkan demi untuk semua.
Semua ini telah diselindungkan. Suasana berubah bagaikan mimpi. Perjuangan
Assalamualaikum and good morning and selamat pagi to everyone. I hope you can hear me clearly. Can give me some response. Can you all hear me?
Okay.
Okay, thank you. Welcome to our first webinar session organized by Malaysia Association of Epidemiology or MAE. My name is Dr. Razita from Universiti Malaysia Sarawak or UNIMAS. For our today's session, it will be uploaded in the Facebook MAE after this webinar session. Okay, MAE or Malaysia Association of Epidemiology is a very new association in Malaysia, and you will listen more of our association after this webinar session. So please stay tuned with us until the end. Okay, the objective of this webinar session is purely on sharing knowledge based on the real experience from our public health medicine specialists who manage the outbreak at the ground level. And some of the action during the outbreak, you will not find it in the textbook or in the classroom teaching. So please listen to their presentation clearly, and please respond by giving your question or put your question in the chat box later, okay? And but for the university, this can be a platform of lifelong learning, part of our lifelong learning, which has been encouraged as a future direct teaching method in the university level. So inshallah, MAE will continue this type of sharing session to increase our public health competencies, not only in the outbreak management, but also in the other domain of public health. Our webinar for today, as you all know, we are still in the middle of COVID-19 outbreak. So it is very, very appropriate. Our theme for today's webinar is Battling COVID-19, Field Experience from Malaysia's Unsung Heroes, which you will not see this in the newspaper or in any TV or any media. So this is a very, very good sharing experience from the first-hand heroes, which I think most of us never know. Okay? So we have 3 speakers, and they are from different states in Malaysia, and also with different scenarios in managing the outbreak. So before we start our webinar session, there are a few announcements that I will make. Please mute your microphone during this session, but you can on your video because I love to see your faces. Because I know some of, there are some very familiar names, yeah? So I love to see your faces on the video. Thank you for those who have done that. And also another reminder for the Q&A, the section for Q&A will be after each presentation. So can you please enter your question in the chat box, and the moderator will choose the question and ask the speakers after their presentation. Okay, so next I'd like to introduce our moderator for today's webinar. Prof. Dr. Saffree is a good friend of me. Yeah, he's a public health medicine specialist and currently holding a position as a dean at Faculty of Medicine and Health Science, Universiti Malaysia Sabah, or UMS. He is one of the National Committee of Malaysia Medical Council, MMC, and a member of International Commission of Occupational Health. Prof. Saffree graduated from Universiti Malaysia Sarawak, which I am very, very proud of because he is our alumni, UNIMAS alumni. And to have him as a dean is a very proud moment for UNIMAS. Thank you, Prof. Saffree. And Prof. Saffree obtained his master from UKM, specialized in occupational health. Before joining UMS for teaching, he served Sabah Health Department for more than 15 years. He has published many papers, more than 50 publications, and has received several awards, and one of it is Excellent Service Award. He is also our editorial board member for a few journals, including Borneo Epidemiology Journal, or BEJ, and also Borneo Journal of Medical Science. So without further delay, I'd like to welcome Prof. Saffree to moderate our webinar for today. Thank you, and welcome, Prof. All to you.
Thank you, Professor Razida Sham from UNIMAS for your kind introductions. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh. And very good morning to all webinar participants. And we can see that at the back, my visual background, that will be our title for the webinar today, which is Battling COVID-19 Field Experience from our Malaysian Unsung Heroes. Yeah. If I could just to reflect when I was a kid, the image of heroes was largely inspired by the Superman comics. A hero was somebody who had supernatural powers like flying, laser visions, or the strength to bend the steels. As a humans, of course, we are all pretty limited in our physical powers. We don't fly. We can't see through the walls. But what unbounded in us is our ability to see injustice and to take them on, often at greater risk to ourselves. My work as a dean and also public health medicine specialist in education has introduced me to many extraordinary heroes with this kind of superpower. They represent the best of who we can be. Their effort to solve the Malaysian challenges demonstrate our values as a society, and they serve as powerful example of how to make a positive differences in the world. And if enough people hear about their actions, they can inspire others to do something heroic too. If there ever been a time that we need heroes, it is now. The COVID-19 pandemic has created unprecedented health and economic challenges, especially for the most vulnerable among Malaysians. The good news is that many people from all walks of life are doing their part to help them. Public health staff on the ground tirelessly working very hard around the clock, and incredible what they have been able to achieve, especially given a quick turnaround time to implement contact tracing and also control measures. To these heroes, everywhere, anytime, thank you for your work you do. Today, we are going to listen from 3 public health medicine specialists who are actually leading among the heroes. They will share their field experiences in battling COVID-19 in their respective zones. Before we proceed to the panel presentations, let me introduce the 3 panels. The panel number 1, Dr. Mohamad Nizam Subahir, will share the response during Malaysia's first EMCO or Enhanced Movement Control Order in Bandar Baru Ibrahim Majid, Kluang, Johor. Selamat datang Dr. Mohamad Nizam, and thank you for able to share your field experience today.
Thank you, Prof.
The second panel will be Dr. Mohammad Azim Raja Harun. He will share about the Enhanced Movement Control Order at prison centers during the 3rd COVID-19 pandemic wave in Tapah Field Experience, Perak. Selamat datang Dr. Raja Muhammad Azim.
Terima kasih, Prof.
Yeah.
Selamat datang.
And the third one, even though it's the last but it's not the least, is my fellow Sabahan, Dr. Haji Mohammad, Haji Abdul Marsudi Manah. He will share about the EOC, Emergency Operating Center at district level and managing confusion of the COVID-19 pandemic. Selamat datang Dr. Muhammad Abdul Marsudi. Okay, before we start our first presentations, let us enjoy the video which is produced by the MME. Please.
Sebentar ku pulang, cari rezeki sebentar untuk aku bawa pulang. Untuk keluarga aku sayang sanggup biar ku tak makan. Janji terasa senang walaupun banyak yang kurang. Asal ku rasa tenang, sebentar ku pulang, cari rezeki sebentar untuk aku bawa pulang. Untuk keluarga aku sayang sanggup biar ku tak makan. Janji terasa senang walaupun banyak yang kurang. Asal ku rasa tenang.
Penat lelaku ku saja tahu, penat manapun ku tak mengeluh. Titik peluku semua tu kamu, titip restuku di dalam lagu. Maaf kalau tak cukup, buat apa ku sanggup. Selagi jasad menghirup, untuk keluarga ku
Sebentar ku
sanggup.
pulang, cari rezeki sebentar untuk aku bawa pulang. Untuk keluarga aku sayang sanggup biar ku tak makan. Janji terasa senang walaupun banyak yang kurang. Asal ku rasa tenang.
Ku tak nak berhenti selagi tak cukup hasilku. Doa berkah dan waktu yang aku perlu. Aku perlu jangan risau tenagaku. Cukup hasrat dan impianku pandu laju. Laju, laju. Ya aku yakin aku mampu. Aku yakin aku mampu.
Sebentar ku pulang, cari rezeki sebentar untuk aku bawa pulang. Untuk keluarga ku sayang sanggup biar ku tak makan. Janji terasa senang walaupun banyak yang kurang. Asal ku rasa tenang.
Okay, welcome back. Now, let me introduce our first panel, Dr. Muhammad Nizam Subahir. He obtained medical degree from Universitas Sumatera Utara in 1999 and also Master of Community Medicine and specialized in Epidemiology and Biostatistics in 2009. And currently, he's the head of District Medical Office of Health in Kluang, Johor. He will talk on the response during the Malaysia First EMCO, Bandar Baru Ibrahim Majid Kluang Johor. Dr. Muhammad Nizam, the floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And very good morning. Thank you to Prof. Saffree for your kind introduction. Ladies and gentlemen, without further ado, please allow me to start my presentation with the title Response During Malaysia First EMCO, Enhanced Movement Control Order at Bandar Baru Ibrahim Majid, Kluang, Johor. This is the map of Johor and Kluang district. For those who are not familiar where Kluang is, it is situated in the center of Johor, while Bandar Baru Ibrahim Majid is located at the Mukim Ulu Benot, in the border with the Pontian district. Bandar Baru Ibrahim Majid or BBIM is about 2 to 3 kilometers from exit Tol Semparangam, Tol Plus, directed to Benot Pontian. This is chronology of event before EMCO BBIM was declared. It was started when 3 people came back from Ijtima Tabligh Sri Betaling to Bandar Baru Ibrahim Majid on 2nd of March, and then first case started the onset on 4th of March. The case was identified when he went to Klinik Kesihatan Semparangam on 11th of March 2020 and immediately referred to Hospital Permai Johor Bahru as person under investigation, PUI, of COVID-19 when we get alert of tablet cluster from KKM on the same day. Then a case started to increase when we did ACD, active case detection. Even we tried to control the situation with the police. And unfortunately, the situation became worse when a total of 79 cases were reported from 12 to 26th of March, just within 2 weeks' time. And in order to contain further spread of the outbreak, the lockdown in the affected area should be proposed immediately. This is a pre-EMCO BBIM Kluang district meeting. When in the morning of 26th of March 2020, I make a presentation to district officer and district disaster committee to give the overall situation and propose for lockdown. The committee agreed and they will discuss with the MKN, Majlis Keselamatan Negara, to get their opinion. And then in the afternoon, we had a video conference with the Yang Amat Berhormat Menteri Besar Johor, and then state government agreed for lockdown and will propose to the federal government. Then around 8 p.m., Senior Defence Minister Yang Berhormat Datuk Seri Ismail Sabri announced the EMCO started 12:09 midnight on 27th of March 2020. The objective of EMCO primarily was to control ongoing public health threat of COVID-19 and to prevent future worsening of the outbreak and to contain it in the area. And number two, to ensure resident movement was strictly controlled. All business activities stopped in order to limit the movement of people and avoid the spread of the disease. Also prevent spread of the disease to other area. Those identified as confirmed COVID-19 will be isolated and admitted to Hospital Encik Besar Jaga Kluang. It's a designated COVID-19 hospital for Johor. And number three, as a platform to communicate with the public on situation of the COVID-19 in the area. Residents in the area will be given advice on personal protection, hygiene, and also this social distancing as the main method in COVID-19 control. Besides that, food supplies will be provided to all residents by the Social Welfare Department during the imposition of the EMCO, and medical base will open in the area. What is the challenges? As we know, this is the first time EMCO being imposed in our country. So there is no guideline, but we must do the right thing with no mistake. Since all over the Malaysia is watching us, we should conduct the best strategies to carry out. And number two, challenges, PPE stock was not enough because we are not prepared in this kind of unusual outbreak. We already indent the PPE, but logistic issue arise due to MCO. While some of my staff also was put under quarantine because contact to the positive case. Also, we need a fast demographic information in Bandar Baru Ibrahim Majid. How many people affected, how big the area that we need to contain, how many people need special medical attention, such as pregnant mothers and patient under dialysis. I have to gather all the information from many sources. And during the outbreak, we need help from other agencies. So what is the best way to coordinate? So the most important thing, we have to give good data and clear situation to our stakeholder. This is the some sharing, gathering information with other agencies and stakeholders. This is a district disaster command response organization chart, which led by the district officer and several other agencies in the district to conduct issues like emergency and rescue, food supply and welfare, and logistic management. And I, as a PKD, I will give the advice to the district officer and also the other agency regarding the needs based on the current situation. While this one is a medical and health response organization chart, I have to command and control many units such as infection control team, medical and public health response, mental health, psychosocial support, and also logistic issues. If I need deployment, staff, and asset from other districts, I will discuss with CPRC, Crisis Preparedness and Response Center of Jabatan Kesihatan Negeri Johor. The role of PKD operational room is very important for the purpose of coordinating tasks, identifying human resource and existing asset before being deployed and to the field and to make case detection or investigation of close contact to positive case. We will also analyze the disease-related data, such as looking at the location factor, patient age, patient travel history, and other demographic data to suit with the issue we are facing, and share the needed information to the stakeholder. We also coordinating the process of disinfection of positive cases houses and coordinating the gazetted quarantine center. And not to be missed, the enforcement of 342 Act, Prevention and Control of Infectious Disease, Act 1988, as well as the task of health promotion. This is the EMCO Bandar Baru Ibrahim Majid coverage area, including 11 villages or settlement with population around 5,300. Then we divided the area into the red zone and buffer zone based on the risk assessment that we have found from the field and data analysis. The red zone consists of area of Bandar Baru Ibrahim Majid, Taman Surau and Kampung Kurnia. Others will put as a buffer zone. A basic food supply were provided from the District Disaster Committee Operational Room. It was located at Majlis Daerah Simpang Renggam. Usually, it will be sent to the affected houses and residents once in 2 days. Food supply of affected area were done by Welfare and Civil Defense Department. For red zone area, they use full PPE, while at the buffer zone area, they just wear a mask and glove. For active case detection, ACD activities, firstly, we did a briefing focus on the strategy of ACD strategy activities and strict safety and prevention requirements toward COVID-19. During briefing, all team members were taught on personal protection equipment, PPE, house surveillance orders, HSO, population risk assessment, donning and doffing, and also the contamination procedure. Other ACD activities mostly did by the PPKP or Environmental Health Assistant Officer from PKD Kluang, and also we got help from other districts. They use risk assessment of COVID-19 checklist and to consider whether it's a high risk or low risk. From the population survey, then they send the list of the residents to the operational room for sampling purposes. Then the operational room also will make a cross-check or verify to make sure the ACD will not miss any targeted houses and residents. Data from ACD team will be compiled by the operational room. Then from the land listing, we shared with sampling team and make a phone call to all patients for their appointments the next day. All residents from red zone are compulsory for PCR swab tests, while the rest from the buffer zone will be based from the risk analysis. For positive cases will be sent to Hospital Encik Besar Jalal Kasum, while the negative cases and residents from buffer zone will be given HSO and repeat RTK antibody at day 13. For preparation for mass sampling, we decided to make a mass sampling at the open hall of Sekolah Kebangsaan Datuk Ibrahim Majid because of the spacious area plus added canopy from local council. The preparation completed until 2 a.m. in the morning on 28th of March 2020. And for mass sampling for RT-PCR were done at the SK Sekolah Kebangsaan Datuk Ibrahim Majid, nasopharynx and throat swab from the upper respiratory tract using the nasopharyngeal swab technique. Sample were brought to Makmal Kesihatan Awam Johor Bahru, MKAJB, and test for SARS-CoV-2. This is another picture of the mass sampling activities. 1,980 swab PCR tests were taken from 28th of March until 12 April, and 52 tests came back as positive for COVID-19. And then we proceed with RTK antibody at day 13. Rapid test kit for antibody were used. Studies suggest that the majority of patients develop antibody response only in the second week after onset of symptom. During this time, RTK antigens did not available in the country. Those with reactive RTK antibody were swapped for PCR testing again to confirm their infectivity status. A total of 2,943 tests of RTK antibody were done during the operation. 83 tests were turned to reactive, and we proceed to nasopharynx swab for RT-PCR test. And while waiting for the RT-PCR results, they were quarantined to quarantine center to prevent the risk of disease transmission. We also provide a mobile RTK antibody team for bedridden patients. For quarantine center for PUS or patient under surveillance, those RTK reactive result were being quarantined in two quarantine center, which is Pusat Latihan Jabatan Kemajuan Orang Asli Jeffree, Kluang, and Institut Tabib Awam Negara Kampus Wilayah Selatan IKWAS. The management of the quarantine station were handled by multiple agencies such as civil defense. Civil defense will manage and coordinate for quarantine station. Others, welfare department will focus on welfare of people in quarantine such as food, basic need, etc. Police and RELA will be focus on general security. Medivest will in charge in clinical waste and linen management. And for this Kluang District Health Office, KD Kluang, will focus on medical health disease and infection control at the quarantine station. At the quarantine center, 83 people were issued for quarantine due to reactive RTK antibody. However, only 71 were placed in the two quarantine center, and the rest 12 were quarantined at their home because they were either from the same house or were alone at home. And among the quarantine, 31 were found to be positive COVID-19 and sent to hospital Encik Besar Jalpas Kluang. For medical base, a temporary medical base was set up at the Klinik Desa Ibrahim Majid. As all residents were not allowed to move out from the EMCO area, this medical base provided 24 hours medical standby for any emergency, outpatient, and maternal and child health. A team from Korps Kesihatan Angkatan Tentera Malaysia, Malaysian Army, led by Major Dr. Mohammad Hairul Amir, had assisted in managing the medical base until 14 April 2020, then was continued by KD Kluang staff. There was no accident reported during the operational of KD Ibrahim Majid medical base. Others, we provide a community health education. Four methods of health education activities have been successfully implemented in the EMCO BBIM, such as individual advice, small group discussion, brochure distribution, and public announcement. A total of 4,150 individual counseling was carried out, and individual counseling activity were also conducted at the screening center at Sekolah Kebangsaan Dato' Ibrahim Majid, and 2,000 COVID-19 prevention leaflet also have been distributed. We also had a drone surveillance during the EMCO BBIM. Drone surveillance were used by the Malaysian Army to ensure that residents were complying with the strict movement and the drone also was used for information sharing and public announcement in the area. For psychological first aid, PFA, the mental health psychosocial support service, MHPSS, at the BBIM was provided by the MHPSS PKD Kluang team and assisted by the MHPSS Hospital Encik Besar Jagasum and also trained volunteers. A total of 246 BBIM residents were contacted by the counsellor for tele-psychosocial support. A total of 144 sampling staff also were screened, and 14 of them had abnormal DAS score and were given intervention, and one of staff had been referred to psychiatrist. PKD Kluang also has received medical team support from the NGO like Mercy Malaysia, consisted of 13 volunteers members, and all of them have medical background and were assigned as part of sampling team in the COVID-19 mass sampling operation at the Sekolah Kebangsaan Dato' Ibrahim Majid from 31st March 2020 until 28 April 2020. This communication is an important role. During EMCO Bandar Baru Ibrahim Majid, there were issues arising from the community regarding their dissatisfaction with their safety during COVID-19 situation and sampling session. The person was informed that all activities in EMCO BBIM were strictly based on standard operating procedure, and finally all issues had resolved smoothly. The demographic distribution of COVID-19 in EMCO with Bandar Baru Ibrahim Majid, here we see 99.5% were Malaysian, and majority were aged 50 and above, consists of 52%, and male was more than female. From the epidemiological curve, majority was asymptomatic, consists of 44.6%, the red one. From the EPID curve, based on symptomatic patient and 83, majority started the onset on 13th of March until 22nd of March. This one may be due to some events such as Solat Berjemaah and in the Surau, and 4 event of wedding ceremony in 14 and 15 March in the BBIM itself. From the analysis, this diagram shows cases by age and system. Majority were productive age is 20 to 60 years old, which consists of 59%. And while fever and cough were the most important, symptom reported. This slide shows the cases before and during the EMCO. We managed to detect another 106 cases of COVID-19 compared to 87 cases before EMCO, and make it total of 193 cases. Majority of cases concentrated at the red zone area in the Bandar Baru Ibrahim Majid Center itself, total of 183 cases, while at the buffer zone area only had 10 cases. Based on data analysis, 87 COVID-19 cases in red zone and buffer zone were detected prior to the EMCO BBIM operation, while 106 were detected during the operation. Diseases has spread into the fourth generation with the index case and those who attended religious assembly in the Sri Petaling Mosque from February 28th until March 2nd. Another three main risk factors were identified as the factor contributing spread of the disease in the area, namely regular mosque congregators, wedding ceremony attendees, and close household contacts. This slide shows the total of number of houses with COVID-19 infection. The EMCO Bandar Baru Ibrahim Majid area show the highest number of infected house percentage with 31.2% or 86 houses, where 43 houses with a single case and another 43 houses with more than one case. Summary of screening. Total population from district census for red zone and buffer zone were 2,599. But we noticed there were foreigners, legal and illegal. So we decided to screen them, plus some people from extended buffer zone, plus the high-risk frontliners. At the end, we managed to screen 3,141 people. And last case was detected on 12 April 2020, but we continue to screen with swab, PCR, and RTK antibody on 13 April, 16 April, 19 April, 20th April, 21st, and 22nd April. We did 1,489 RTK antibody and plus 172 swab PCR, and all results are negative. And then we're confident enough to end the EMCO on 28th of April 2020. There were 4 COVID-19 cases death reported from the outbreak area. All of them were male, aged from more than 60 years old, with a multiple comorbidity, such as diabetes, hypertension, and ischemic heart disease. And burial has taken place in various locations under the supervision of Environmental and Health Assistant Officer. During Operation BBIM, the contamination process was performed for all COVID-19 patient houses. A total of 99 houses had been decontaminated in this operation. We collaborate with other agencies, including our staff, KKM, 17 staff, from the fire department, 50 staff, from the local council, Majlis Daerah Semparangam, 25 staff, from local council, Majlis Pendaran Kluang, 8 staff, and from SW Corp, 6 staff. And as for non-COVID houses, local district authority in collaboration with the PKD Kluang has distributed decon kit along with instruction for each houses. Finally, COVID-19 outbreak Bandar Baru Ibrahim Majid was declared ended on 12th of May after no more cases detected in 14 days since we ended the EMCO on 28th of April 2020. And I am honored to be given a certificate of appreciation from the Johor Yang Amat Berhormat Menteri Besar, Datuk Dr. Engineer Haji Asni bin Mohammad on 28th of June 2020 at Sekolah Kebangsaan Datuk Ibrahim Majid. Okay, that's all. Thank you very much.
Thank you, Dr. Mohamad Nizam. big congratulations to you and your team. I think being the first EMCO in Malaysia, you know that it's very difficult to work with because you did mention your challenges. There's no guideline at all.
Yeah.
Not enough PPE, a lack of demographic data and the multi-agency coordinations. And 183 cases, and for that, and you managed to contain it within a month. I think that's such a very fantastic coordination and controlling this outbreak for the EMCO. So congratulations again. Now maybe I open to any questions. I can see that from the chat box. Dr. Nizam?
Yeah, Prof. Thank you.
Yes. Yeah, the first question is from Zahir. What are the key factors in the success of controlling the COVID-19 outbreak in this area?
Okay. Bismillahirrahmanirrahim. Assalamualaikum and very good morning. Thank you for the question. So the main factor, I think, is the close and good cooperation with all agencies involved, the musyawarah and the trust of each other. At this time, all the issues, weakness, problems that arise will be discussed to be improved from time to time until it can be resolved properly. Apart from that, it's also existent from NGO just now, I said, like Muslim Malaysia, Muslim Medical Association, Assemblymen, community leaders, and public concern, who always give us support and motivation to end this battle with victory. Thank you, Prof.
Great. So the key point here that under your leadership, you need to work with others. Is that collaborations and coordination. Of course, we need the uptake in terms of cooperation from other agencies and also from the recipient, which is the community. So that is probably is lesson learned from us today. So now we move on to the second question. You mentioned that this is from Dr. Sheikh. You mentioned that more than 3,000 residents have been inspected in this area. Yeah. How did you organize strategies with the relevant agency, and how about the acceptance of the population then?
Okay, thank you for the question. First of all, risk assessment as well as teamwork are very important. This operation just now involve various agencies such as district office, local council, police, army, welfare department, and Ministry of Health itself. It is headed by the Kluang district officer, and each agency have their own role. And every morning, we will have a brief meeting with the all agency chaired by the district officer, and we will discuss for whatever problem arise from the community. And for all issues, we manage to settle it wisely. We also discuss with the head of the community to ensure that the community understand and the rationale of the action taken. And Alhamdulillah, they give excellent cooperation. While within in our health department, we have a special team to conduct for various activities, such as active care detection, medical team responsible for sample taking and case management, decontamination, health promotion, as well as MHPS. They work tirelessly. In terms of preparation and implementation, our members and other agencies work 24/7. That was very excellent.
Great. That shows that your leadership and coordinating, you mentioned about the risk assessment. I think this is very important, how you want to stratify your strategy and give a priority. Okay, we still have a lot of time. So the third question, this is from Nelson. May I know what kind of intervention given to our staff at managing their mental health issue? You mentioned just now you are doing this sort of DAS assessments, yeah. So how you deal with this? Because we know that they are tirelessly from early this year, then maybe you end up with one out. Maybe you can just respond to that.
Okay, thank you for the question. For every activities that we had, after example, after sampling and after decontamination or after ACD and everything, we'll make a debriefing session after the session ended, and from that we'll ask our staff what happened and what are the problems that they have facing, and then we will discuss and manage it. And also we had a online DAS screening, okay, and some telephone call, consulting for our staff, maybe who had any difficulty in this challenging time. So we also having a debriefing session with the all agency, also to our DO, and we invite one of the our staff who had positive COVID-19. They shared the experience, and this give us some very good motivation. We have to fight this until we win. That's all, bro.
Great. So we don't forget about the occupational health. They are all our so-called weapon to combat these things. Okay, then we move on to next questions from one Amirul mentioned that, is it worth to carry on EMCO in this area in view of the economic impact versus health of the community?
Yes, I think we should implement because we don't want this problem will going to another places. Maybe we should contain it, and we control, we manage it, and that's the most important thing. Before the disease transmit to the other area, I think the EMCO is very, very, very important.
Good. So as mentioned by you just now, the challenges, we don't have experience, not even single person in Malaysia. We need to learn from China, but they have different demography. But since you are the first EMCO, I think this thing you need to don't take a risk by looking into this. But this is happened during the first, I think the second wave, yeah, in March like that. So we don't have any much experience and also information how to combat this thing. So I think in terms of cost, I think there is no cost at all if you can just make sure that this thing. But now I think probably if you can have this, maybe you can look into the cost factors. Yeah.
Yeah.
Okay. Now we go to the next question mentioned that from our president, Prof. Haizat, mentioned that. Will you please share with us your most unforgettable experience from this outbreak?
Okay, thank you, Prof, for the question. As we know, this is our first EMCO in Malaysia. I always feel bonding and a bit anxious because there were no specific guideline, while the whole country give attention to, and focus to us. We cannot make a mistake. We have no choice, and to make it the best plan and implement it because it will become a reference to others in the country in the future. Apart from that, another experience that I cannot forget is that when the EMCO started, 2 of my staff also positive COVID-19, and as a result, about another 45 of my staff had been quarantined for a few days while waiting for their swab test result to be obtained. Besides of a shortage of staff, I also have a shortage of PPE due to the logistic issues impact from the MCO in the country. But Alhamdulillah, we gradually able to manage, resolve all the issue. And not to forget, thank you to the whole community who always give us encouragement and motivation to us as a frontliners to continue to carrying out this challenging task with victory. Thank you, bro.
Great. So that is really wonderful experience. Yeah? The next question is from Nelson. You mentioned that 52 cases turned out to be positive out of 1,980 being tested.
Yeah.
For PCR, yeah? PCR, you know, PCR costly more than 300 ringgit up to 500 ringgit.
Yeah.
You think this is cost effective? Is there any operational case definition for you to selecting the population for screening?
Okay. For the contact case for positive cases, we don't have any choice. We have to take a PCR, and then for those if you want to make a surveillance, and maybe I can suggest for RTK antibody, but we have to wait maybe until second week. For in the Ibrahim Majid, actually we focus on the Bandar Baru Ibrahim Majid itself, the center one. Okay, so that one we make test for all of them, and for others in the buffer zone, the rest from the risk assessment, if they are not in the high risk group, so we just make a RTK antibody at the day 13, and this one could be from if we compare to the cost, it's much more lesser with RTK. That's all.
Okay, so means that you're suggesting that you admit that that is a bit costly as compared to the rapid test, yeah?
Yeah, that's it.
Is there any that maybe because the question is about the operational case definitions,
Yeah.
for you to proceed to select probably while you're doing active case detection. So you screen all the population in that captured area?
No, actually we do analysis, and from the ACD team, they make a risk assessment at the field. So from that, we can analyze it in our operational room. Just now we see that from the map, most of the cases is just from the center of the Bandar Baru Ibrahim Majid, but from others side, from buffer zone and another area, just only very less risk for the COVID-19, because maybe they are not praying at the same mosque, or maybe they're not using the same road. That one we have to analyze what is the risk for the COVID-19 transmission. That's why I just focus on the red zone and then bit to the buffer zone, but not all.
So EMCO means that they will total lockdown at home, yeah?
Yeah, that's true.
Okay, so we move on to the next question mentioned. This is from the Gary Go. How was home surveillance done for the quarantine patient during the outbreak?
Okay, as we know, at the EMCO area, there will be army and police will make SGRs or roadblock at every corner of the area. Also, we have, and from our operational room, we'll make a call whether there is any problem, if there is at home. So our team just now, and with the police and army, some of them will be back using a petrol car. They will go house to house. And just now I mentioned I got help from the army using the drone. Okay, we can use the camera from the drone that we can see if the resident at the Bandar Baru Majid are complying with the order for the house surveillance order.
Okay, so that is such, very good. They'll be using the innovative tool by using a drone to comply with the order. But I think this question is about the home surveillance, how you monitor probably the symptoms. Is there any daily things need to call respondent, or is door to door every day?
I don't think we are able to go to door every day, but we have another head leader in the district, leader in the village. Okay, they were as our counterpart in this kind of disaster. Okay, the people from the village can contact their ketua kampung, and then all the issues that arise from the community, they will pass it to our bilik gerakan.
Okay. The next question from Rozani mentioned that how do you define the buffer zones? I think outside this BBIM.
Okay, thank you for the question. From the analysis, cases prior of the EMCO, the cases concentrated at the BBIM itself because of the events such as the most congregators, praying congregators, and the attendees of the wedding ceremony. So outside of the BBIM center, okay, we have made an analysis. They have no connection or good relationship with the BBIM in view of the COVID-19 transmission. So that's why we define it as a buffer zone. And if the buffer zone there is a higher risk of case, there is increase of case, maybe we have to extend to another area. But luckily, from the analysis, the buffer zone just now we can see just only 10 cases compared to the BBIM center 183. So we are sure that the buffer zone is quite safe enough, and the others place also in good control.
Is there any like the radius kilometer to say that is buffer zones?
Okay, radius was we discussed with the police, and they said because BBIM they have many road they can access. So actually we contain about 20 kilometer radius. 20 kilometers, 5 kilometer radius, but 20 kilometers square. So it's a big area because we don't want to people from the area to going out from the EMCO area. So for 20 kilometers square, about 5,300 just now I said, but we only screen about 3,141 is because due to the risk assessment. Okay, where the low risk area, we just ask for the symptom and also from the RTK antibody that we have, we make for the surveillance, all are negative. So we are confident enough that the area was safe.
Great. So I think this radius will reflect that the total amount of resources you need to, deploy them to the field. Okay. So the next question is from Ahmad Nabil, that there were illegal foreigners too in the area.
Yeah.
And do your team have difficulty in tracing them? And as usual, the illegal will run away as they're assuming we will catch them. So what do you think? I remember there's 2 or 4 cases of the foreigner. Yeah.
Yeah. We have a total about 146 illegal in the area, where the foreigner 146, where 12 of them are illegal. They are working in the kebun sawit and kebun getah around there. Okay. We mentioned about this. The community leader actually they have a concern. They passed about this foreigner to us, and then we discussed with the police. And actually, they are very willing to make a test for the COVID-19 because they also afraid if they have the disease and make it spread in the area. So actually, we are having good relationship with the community leader and the police and the immigration, and all of them are able to be screened, and only 2 of them will be positive for COVID-19.
So since the word is illegal immigrant, means that after they will lock down, then you will deported to the under immigration law.
Yeah. After the operation finish, and then I just passed the illegal name to the police and immigration for the action. But I have to finish the test and screening first.
Great, great. I think maybe we go to the last questions here. From Cairo Nizam, what is the impact from MHPSS to the community? What is the challenges when you perform this? So when is it the most ideal time to deploy this MHPSS? I think you more on the procedure.
Yeah, MHPSS is actually very important, but we have to implement it at the right time. Mostly we did for those who their family members had died for COVID-19. Usually we make a phone call, make appointment, what is the best time that our team can see them and give some maybe some advice and counseling. After they agreed, then we came to their house, give them some motivation and what they should do. Okay, from if they are not willing to see us, maybe we just give counseling from telephone, from telecounseling. Okay, that's all.
Okay, so the last question from me. So I heard that yesterday. Yes, yesterday. Unfortunately, you declared another EMCO in your area. So can you just share with us your experience from this EMCO, previous EMCO, how you want to make sure this current EMCO, since you managed to contain within a month, can you able to shorten to become 2 weeks?
Yeah, these challenges will always come. Okay, yes, as we know, yesterday we just declared the MCO at the Kluang prison. Okay, this is different of type of MCO compared to BBIM. It's an institution. But yesterday we have a meeting. We have a good meeting with the other agency, with the hospital department. Okay, I think we can manage it within 2 or 3 weeks, maybe, because for me it's quite bit easy because they are only in the institution at the closed zone compared to the area like Bandar Ibrahim Majid. But just wish me best of luck.
Thank you. Thank you, Dr. Mohammad Nizam. I think it's such a wonderful experience to us here. We hope that for the current challenges, which is happening since yesterday, so I hope you can coordinate as early as possible. Thank you, Dr. Mohammad Nizam. Thank you. So can we just conclude here from the first presentations that the coordinations, interagency collaborations, coordination, and good cooperation from interagency and committee is the paramount role in the combating this COVID-19. And the second one is the effective leadership. This is I must respect this leader, especially this Dr. Nizam and the team, is that you're able to make sure that your weapon will able to deliver to all these areas. And the third one, your strategic planning. I can see that the way you organize by functions, where actually we're able to contain with this because the time is a 1 month time. And not to forget also, you also look after the occupational health issue, especially the mental health. We know that with around the clock, probably this is it will cause exhaustion, and then probably this is you have to make sure that they will have the continuity of this contact tracing and all the control measures. Thank you, Dr. Mohammad Nizam. Thank you. Wish you luck. So you are all our heroes. Thank you.
Thank you very much.
Okay, now can we move on to the second speaker? Yeah, the second speaker, second panels, Dr. Raja Muhammad Azim bin Raja Harun. He obtained a medical degree from Universiti Kebangsaan Malaysia in 1998, and also Master of Community Medicine from Universiti Science Malaysia, and also specialized in occupational health in 2009. Currently, he's the head of the District Health Office of Batang Padang District, Tapah Perak. So he will share to us enhanced movement control order, EMCO, at prison centers during the third COVID-19 pandemic wave, Tapah Field Experience Perak. Dr. Raja Muhammad Azim, the floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi taala wabarakatuh. Salam sejahtera and very good morning to everybody. Thank you very much, Mr. Moderator, Prof. Saffree, in introducing me, and thank you to MAE who invited for me to present for today Tapah Field Experience on enhanced movement control order at prison center during the third COVID-19 pandemic wave. This is my content of presentation. It include of introduction, objective, chronology of event, results, public health strategy and response, challenges, conclusion, and references. So as introduction, COVID-19 has spread at a rapid rate by droplets on a global scale. The first case in Malaysia happened in 25th of January 2020, when 3 Chinese nationals as close contact to a case in Singapore landed in Malaysia. For the second wave in early March 2020, as we know as Tabligh cluster, and the third wave, COVID-19 in Malaysia happened in 20th of September 2020, when 3 states affected badly. For then, the government strategy is to revert from recovery movement control order to conditional movement control order and enhanced movement control order. Prison. Prison means any house, building, enclosure, or space, or any part thereof declared to be a prison under Section 3 and shall include the grounds and buildings within the prison enclosure and also the airing grounds or other grounds or buildings belonging to attached thereto and used by prisoner. Prisoner is a person, whether convicted or not, under confinement in a prison, and in relation to a convicted prisoner includes a prisoner released on parole. I can divide the prisoner into 2 categories, which are remand detainee, is defined as have not been to trial, nor have they been sentenced or convicted to any crime. And number 2 is convicted prisoner, is a convicted of a crime and put in prison for a period of time. Most detention centers in Malaysia, including prisons, were affected with COVID-19 pandemic and cluster. The risk of spread of disease is due to close environment, overcrowding and close proximity, underlying burden of disease and existing diseases, worse health conditions, weak immune defense, such as stress and poor nutrition, illegal immigrant, or we call as party, regular movement of people in and out of prison, including employees and visitors. I would like to introduce you Tapah Prison. It's located 12 kilometers away from Tapah Town Centre and District Health Office, PKD, and it is about 63 kilometers from Ipoh. It started operational in 2004, and the area is 81.75 hectares with a maximum capacity of 2,200 inmates. In average, at one time, they have 2,900 inmates, but sometimes may up to 3,200 above the maximum capacity. In 2020 admission, up to October is around 6,000 to 7,000. And these two categories of prisoners, which are remand detainees and convicted prisoners, are here. And under an area under coverage were Perak and also Selangor. This is the simplest way that I can show you how the flow on prisoner admission and release. So as we know that a person who are arrested by the police or other enforcement authority will put into lockup, and afterward they will sent to court for the sentence of imprisonment, and by then they will go straight to the prison. This red triangle shows area of prisons, and they will go first to the prison record office, and this is very critical point in which all the prisoners will register whether it is admission or release. And after that, they will put under 14 days quarantine under Prison Act for the security purposes. And afterwards, they will put in the general pools as duration as stated by the court. And after complete the period, they will release to the community, or for the illegal immigrant, they will send to immigration depot. This is the simplest way to describe how the flow on prisoner admission and release. EMCO and Tapah Prison, as we all know, it is already announced by our senior minister security cluster on the 22nd October 2020, on the day of EMCO itself. It is enforced starting from 22nd of October up to November 4th. It is 14 days EMCO, and including the North Zone and Selangor Prison. Tapah is one of it. Enhanced movement control order means total lockdown. And we have two supplements or SOP that already produced by prison, prison SOP in handling COVID-19 case, and also prison SOP in handling transit center, in which that complement that our Ministry of Health SOP for COVID-19. As we know that for EMCO, no one is allowed to come in or go out, including visiting family members. And for prisoners awaiting release will be segregated. There was a letter from Jabatan Penjara Malaysia for no inter-prison movement. This is one of the risks to COVID-19 spreading from one prison to another, and also no visitors, no family visitors to come to the prison. The objective of EMCO is to screen all inmates, staff, and family members for COVID-19, and to isolate and treat COVID-19 cases in designated hospitals, and to quarantine all close contact under CDC Act 1998 within 14 days. This is our chronological of event. We already started in May in screening all illegal immigrants during admission to prison. In total, that we have 567 illegal immigrants, and all were negative. In June and July, due to the COVID situation in Sungai Buloh and Kajang prison, we initiate to screen all 230 remand detainees temporarily transferred in from Selangor prison and were tested negative, and their officers in contact with the detainees. Starting from 12 October, in view of COVID-19 situation in Northern Prison, we start our surveillance screening to all new admission. In 12 to 15 October 2020, we already screened for Block Insaf for the convicted prisoners. On the 16th October 2020, we screened for Block Ehsan all the remand detainees. On the 15th of October, we received a prisoner transferred in from Kedah prison and Pulau Pinang prison. And on 16th of October, we detect our first case of COVID-19 among remand detainees. And 4 cases were from Block Ehsan. And on the 17th October, there was an order for no prisoner movement, transfer in and out to and from Tapah prison. And on 20th October, the screening for female block, we detect 3 COVID-19 cases. And on the 22nd, EMCO for Tapah prison announced, and the District Disaster Committee activated, and the meeting was done on the same day. On the 23rd till 25th of October, we detected another 6 more cases, including 3 female prisoners, 2 staff, and 1 family member. On the 26th, Tapah prison cluster were announced, and on the 30th of October, the last case COVID-19 were detected. Results. COVID-19 screening achievement and attack rate for Tapah prison cluster up to 5th of November 2020. So if you can see here, a total of 3,919 screening were done to prison officer, admin staff, inmates, and also the family members. And we can see that out of this screening, we found that 14 were positive, giving the attack rate of 0.36. We able to achieve all 100% screening, and we can see that the highest attack rate were in prison officer, 0.42%. Otherwise, it is less than that. For social demography of COVID-19 patients, we have 1 case less than 18 years old, and the others were between 18 and 60 years old. 57.1% were male and 42.9% were female. And majority, 85.7% were Malaysian, and 14.3% were non-Malaysian. This is our epidemic curve for Tapah prison cluster. In total, that we have 14 cases. If you can see here, the first case were detected on the 16th of October, and the last was on the 30th of October. The cases that detected on the 16th of 11 is not from was not from this cluster. It is from the other cluster. So if you can see here, the case detection is within the EMCO period, the yellow line here. And at the end of 30th of November, we declared the cluster, the Tapah prison cluster end. And all of the prisoners were asymptomatic. So this is a pictures to show the relationship between all cases. And most of the cases were sporadic. And we believe that they get the infection from the prison itself. But on the 20th of October 2020, we have 3 cases in female remand. And also, at the same time, they have their contact, and the contact will turn to positive on the 20th of October 2020. Make it that this is our local transmission and cluster was announced on the 26th of October 2020. Because these female remand and female prisoner were put in the same cells. In combating COVID-19 in prison, we have strategies and response. So I can outline 11 strategies and response: situational analysis, surveillance and preparedness, interdepartmental collaboration, gatekeeping, infection prevention and control, COVID-19 screening and lab capacity, case management and low-risk COVID center, quarantine, risk assessment, capacity building and enforcement. So for the first, I would like to describe on situational analysis. Apart from our daily press conference by our DG and our senior minister, we easily can monitor the condition of COVID-19 in prison in Jabatan Penjara Malaysia Facebook and also their website. It is available, but very unfortunate, it is not consistent, but it's available. So we can monitor, we can see the color coding and the risk. And also we can see the trending in the numbers they also publish in the website. So for surveillance and preparedness, we already started pre-EMCO. As I said before, the COVID screening to illegal immigrant started since May 2020, and COVID screening to inmates who were transferred in from affected prison already started in July 2020. Several preparedness and coordination meetings were done, comprises of prison representative, PKDs, hospitals, and state CPRC. On the day of EMCO, this district disaster committee were activated. It's led by district officer as MKN representative. The secretariat was from Malaysia Civil Defence Department, or APM, in handling the situation, and other departments as well, such as police, welfare departments, pejabat kesihatan daerah, hospitals, and others. For gatekeeping, police will cover in a main gate to ensure that EMCO policy for no in and no out. They only allow for raw food supplier to go in and solid waste disposal contractor. For utilities department such as Tenaga Nasional Berhad, Lembaga Air Perak were postponed for the meter readings, and police will facilitate in the condition of medical emergency or in a funeral. And at their main gate, they have My Sejahtera and temperature, symptoms and monitoring. The second gatekeeping in triage counter, it is in front of the main gate of the prison. All prisoners, this is meant for all prisoners, admission and staff, is done by Assistant Medical Officer Prison Clinic. They will monitor the temperature and symptom monitorings. For infection prevention and control, for staff, a dedicated staff were put for handling quarantine cells as compared to prison cells, in which the quarantine cells are more risky because they receive a new prisoners. These dedicated staff will stay in the quarters. They will provide hand soap for hand washing and also hand sanitizer. The attire, they are allowed to use a track bottom and t-shirt instead of uniform before, and all their attire will give to prison laundry services. In the other word, they come with their own attire, and before they go back, they will change to their new attire. For the prisoners, meals were served in the cells. They were asked to do a frequent bathing and also hand washing. Some initiative done by the prison to decongest cells by opening the second level in some general pool blocks. As we know, for the prisoner who are sick, they will bring to the clinics, but not during the EMCO, in which the doctor will go to the prisoner cells. And for the linen handling, the master clothing, they will give to prison laundry services. For record office, as I said before, record office is the high risk area. Before this, they use only main gate for admission and also release. But after the AMCO, they already changed the strategy by allocating main gate for admission and also the side gate is for release or from prison to prison transfer. Disinfection were done by a trained prison officer by using a germicide or steriquat every 12 hourly. In the cells, disinfection done by the checkers. The checkers, also known as banduan kerja. And they also use the same chemicals, germicide, steriquat, and they did it every 12 hourly. COVID screening and laboratory capacity. The line listing were prepared by the prison and they were sent to PKD one day before the event. And PKD will do all the preparation of forms and also containers and the prepare for the schedule for swabber team from PKD hospital and prison clinic. For the first screening, they will do for RT-PCR. But for contact, they will do the second screening RTK antibody on the day of 13. If the RTK antibody positive, they will proceed to RT-PCR. COVID-19 screening, the logistic-wise, we use a vehicle from PKD for transportation, and laboratory system, we use SIMCA. And the samples for RT-PCR was sent to Ipoh Public Health Laboratory, where else RTK antibody were done by lab technician on field testing only. For case management at low risk COVID center, the case management to referral hospital, 14 cases were referred to COVID hospital, HRPB, Hospital Raja Permaisuri Bainon and Hospital Tolok Intan. Prison MO were consulted ID physician and notification were done under CDC Act. Patient transferred to designated hospital using klinik kesihatan ambulance and team. Upon discharge, transport were arranged from prison vehicles. Prison officer will accompany the prisoner. Setup of low risk COVID center. High risk for huge cluster, of course, and also the security reason because of the restriction of inmates and staff mobility. With these two reasons, there are needs to set up a low risk COVID center. First of all, the identification of prison blocks and plan of setup by various departments, including pejabat kesihatan, hospital, and also prison. In this setup, there will be an in-house treatment and monitoring for all mild cases and will refer to COVID hospital for moderate and severe cases. And hospital staff will deploy to this setup. For quarantine under CDC Act 1988, so for staff and family contact to positive case, the list will identified by PKDs and decision of place of quarantine. Either they will put as home quarantine or in quarantine station in Institut Latihan Kementerian Kesihatan Malaysia Ulu Kinta or in Institut Latihan Statistik Malaysia Sungkai. They will put quarantine in 14 days and they will supply with home assessment tool. And PKDs will monitor the daily temperature and symptoms. For inmates contact to positive case, the contact list will identified by PKD, and the identified quarantine cells set up by the prison officer, and they will quarantine for 14 days and daily temperature and symptom review by the prison clinic. For school contact to positive case, so is identified by PKD. They all were put on home quarantine and they have a family members monitoring with home assessment tool. Okay, under release or discharge prisoner, so as we know that the policy is no in, no out, but for the release or discharge prisoner, there is no in-house prison quarantine under CDC Act will allow. So it is conflicted with prison discharge policy. By then, we have to send to quarantine station for homeless inmates, or we can put them on home quarantine when family members pick up at prison. For the logistic wise, will be arranged by prison and APM. We also did risk assessment. This is based on district risk reduction program. Assessment for district is a continuous assessment, but for prison, we assess at the end of the EMCO to give feedback to Ministry of Health. And we found that the risk still moderate, even though all were screened and we already segregate all the contacts and also the cases, but because of the overcrowding inside the prison, the risk still there. In terms of capacity building, we did training in prison disinfection, training in donning and doffing of PPE, training in hand washing training in managing linen and laundering to prison officer. And also we did a credentialing in privileging for oropharynx swab and nasopharynx swab for prison MOs as assistant medical officer. We did enforcement as well, especially for home quarantine. After they put in home surveillance order, we did a random checking for staff and family at home. And for latest development, we have prison transit. And this additional, for number 4 is transit, in which they were put in transit for 5 days before they enter to the main wall. So by then, they have to do screening and do the symptom checking. And after that, if it is really free for COVID-19, they will go into the prison. Challenges. For EMCO, we have to put high effort to achieve 100% screening on prisoners, staff, and family members within 14 days. As we know that prison is not area that easily can go in. So we only allow to do sampling during weekdays for prisoners due to security reasons. And we took a weekend for do a screening for staff and family. For medical services to all staff and family, they are not allowed to go to the nearest clinic. So we open our mobile clinic there, and they will call 999 for emergency services by hospitals. For the cluster, all cases were asymptomatic, and by this, we need to do mandatory COVID-19 screening upon admission. And prison clinic functionality during crisis, as one of the prison clinic staff were identified positive, and all the others are considered as close contact and were quarantined. So we need help from a team from other hospitals and also PKD to the prison clinics. And we also manage with pejabat pendidikan daerah for school involvement and also closure. In conclusion, interagency collaboration is a mainstay for the management of COVID-19 in the district, in which we're able to handle EMCO smoothly, manage to do 100% screening and handle cases and contacts, manage to handle COVID-19 cluster successfully without EMCO extension. And this is my references. And I would like to thank Tuan DO, Tuan Syahrul Effendi bin Baharudin, Tapah Prison Director, Tuan Kamruzaman, our team in PKD, Dr. Nadra, and team, our state CPRC, our Tapah Hospital Director, our Prison Medical Officer, and Assistant Medical Officer in charge of Prison Clinic. And not to forget, thank you for inviting me for Malaysian Association of Epidemiology. By then, thank you very much for all your attention. Thank you.
Thank you, Dr. Raja Azim. I think that's such a wonderful presentations. You share in the institutions or prisons how you are tackling this issue. Well, if you know that just now he highlighted about the challenges in prison where actually overcrowding issue is everywhere. Every prison in Malaysia is overcrowding issues. Like yesterday is already declared in EMCO under Kluang. So I remember in our area in Sabah, so we have Ops Benteng in Tawau Lahadatu, where actually there are issue about these prisons. So overcrowding issues, closed environments, existing comorbidities, and also this illegal immigrant is there in that institutions. So I just want to ask, maybe I'm the one first asking your questions, Dr. Raja Azim. Are you there?
Okay. Yeah.
Yeah.
Can you hear me?
Yes. Yes.
Okay. All right.
When you choose the tabulation of this, there is a 14 cases, and there's male and female. I wonder how this will be a present of cases with two gender. If I'm not mistaken, they are under different buildings. They are well separated as the prisons. So how is it? Is it introduced by the the staff, or what is your investigations?
Okay. Thank you, Prof. Saffree. So, based on our investigation, we found that the introduction of cases from transferred from other prisoners, as we know that other prisons are really badly affected during that time, especially on the northern region. So when they brought in all the prisoners in, especially for the remand detainees, so in that case, we found that all of our cases were from these remand detainees. It shows that it is important for us to screen in the first place, because remand detainees, they are not put in the general block yet. So it means that they are still, I can say, in the middle of the prisons. So if easily we can screen them, definitely we can detect. But actually it is really late, because it is already inside the prison. And we know that they are in contact with all of our staff and our medical staff as well, and also what we call as checkers or banduan kerja, because banduan kerja is actually from a general block, general pools itself, and easily they can bring into the general pools if they are infected on that day. So from our investigation showed that it is from detainees. Okay, means that they are newly admitted and within 14 days in the quarantine under Prison Act.
So are you saying that there is no internal or local policy with regards to inter-detention center transfer to screen or to segregate? Is there any policy on that?
Initially we don't have that.
Okay.
That one is based on our initiative to screen. Thank you to Jabatan Kesihatan Negeri Perak, because we already initiate this, in which that in the initial part that we found that many cases were from illegal or illegal immigrant, as we know that happened in Sabah. It happened in some other parts in Peninsular Malaysia as well. So somewhere in May we already started the surveillance, means that we already took the samples up to 12th of October, when we received a letter from Ministry of Health stated that we need to screen all these remand detainees, then we will start screening for all.
Yeah, good. So it's not about screening all, but I mean there is a time because the pandemic is throughout the year. It's not that we can't really prevent another cluster outbreak in that particular detention centers. Yeah, because I think the way they want to spread to the particular detention is very fast because of the situations. So now move on to the next questions from Dr. Said. We have several prisons and pusat tahanan immigration. What is your best advice to prevent future outbreak in these facilities?
All right. the best way is to screen them to ensure that they don't bring a single COVID into the prison. So the best way is doing with the latest development currently. They have to set up a transit center in which they have to they are not in the main wall yet, in between, but inside the prison compound. They have to admit there for at least 5 days, and they will do the thorough checking and also the sampling. And once it is really negative, they will send into the prison itself. So that is the best way in which that we have to ensure the gatekeeping over there lah. Before even a single virus come in also is a disaster to the prison.
Good. So now is the best time for us to convince this authority to have the local policy with regards to the screening, because we're going to prevent these infections in the prison. Yeah. Okay. Good. Now we go to the next questions. From Gary Go. How about differential diagnosis of tuberculosis among the inmates if the result for COVID-19 is negative, yeah, during the EMCO period?
Okay, thank you very much. We have several programs going on in the prison. As we know that, especially for TB, tuberculosis, screening for HIV, and now we have a new programs, hepatitis C in prison, and at the same time we have a methadone program also in prison. So we are not put behind these programs. Yeah, means that even though we are at the higher alert of COVID-19, but we still thinking of the other disease as well, such as tuberculosis, because they might have the same kind of symptoms. And during the admission in the transit station, they are really focusing on COVID. And after 5 days, they will go into the quarantine under Prison Act, 14 days quarantine under Prison Act. At that point of time, they will screen for all kind of requirements and diseases needed. That one is including tuberculosis, HIV, and so on. So many, because they still have ample time to do the screening for 14 days inside there.
Now, what the question means, if let's say your screen is negative for COVID-19,
yeah,
are you going to proceed with the TB screening?
Oh, okay. We have a guideline on this, on assessment of risk assessment and also a symptom assessment for TB in prison. So usually they will do this a symptom review first and do the examination, because in prison they are really limited for everything. They don't have X-ray services, and to bring out the prisoner to our nearest clinic also quite difficult because security reason, and they need sometimes 2 and more staff to accompany. Yeah, based on this assessment, if they think that the symptom is fit for tuberculosis, they will take these sputums and they will send to the nearest clinic. Thank you, bro.
Thank you. The next question is about from Rosanin. How do you control the movement of the staff who live outside the prisons, prison area or EMCO? Whether given special pass to enter the EMCO or any admission to low risk centers? And what were the criteria used for admission to low risk center? That actually those 2 questions. The first question is about the staff. how you control the movement of this among the staff?
Okay, thank you very much for that question. Very good question actually. We already discussed with pengarah penjara to ensure that all staff will bring all their clothing and also their needs to the prison. Actually, the proportion of staff staying outside is only 10%. 90% are already stayed in the quarters itself. So much more easier for us to handle it lah. But this 10% of staff, we already because of EMCO, we asked them to go in and stay inside the prison, and dorms were provided. Yeah, they will stay. They will leave their families behind. They will dorms will be provided, and they will stay in the dorms. So it means that in terms of monitoring, in terms of their welfare, all taken care by the prison pengarah penjara.
Great. How about the second questions about the criteria used for the admissions to low risk center?
Okay, thank you. Actually, we have only 14 cases, yeah, and we managed to handle it with our counterparts, hospitals, referring hospitals, referral hospitals, Hospital Raja Permaisuri Bainu Ipoh, and also Hospital Teluk Intan. So for a low risk COVID center is a place that we already planned, but still not on yet. But for the criteria, about the criteria, this is only meant for mild cases. So with a category 1 or 2, so they will admit there. But for the patients who are having bad conditions, symptoms, comorbids, all that, we still have to refer to the referral hospital.
So means that there is criteria to send to them. Okay, good.
Only mild cases only will stay in a low risk COVID center.
Okay, good. The next is from Kamarul Zaman. Kindly explain more on the school involvement in this cluster.
Thank you very much, Prof. As we see from my presentation just now, that we found that one case was from contact of the family members, if you can see before. So this is a standard 4 students in which they went to school. So actually the condition in the prison itself already started earlier. It means that we detected a few cases before EMCO. So it means that their family are really aware regarding condition in prison, and also school also quite aware regarding the condition in prison on that time. So due to that factors, the family members are taking one step ahead, not allowing this kid to go to school. But from our investigation, we found that this kid already went to school for several times. I mean 2 or 3 times, something like that. And we managed to trace their contact in school. But as we know, the school is situated outside of the prison area. It is about 5 kilometers away. And their transport, usually they use a bus vehicles lah. Okay, arranged by prison department. And also we know that school have very good SOPs in handling COVID. Yeah, everybody knows that. So from our screening, we didn't detect any of the close contact from the other classmates and also the teachers for COVID. So everything are negative. Everybody as contact were negative for COVID. Thank you, Prof.
Okay, thanks, Dr. Raja. I think we already posed few questions to you, so I might conclude that based on your presentations. It's similar to that the first panel mentioned, that is the coordinations and also collaboration, cooperations among all interagency is very important. And then the way you organize this thing, your team. And the difference is with the just now in community, and this is an institution, you're focusing on the infection prevention and control. Or for example, like in hospital, we're talking about infection control, because this is very important. We don't want that is like in the hospital, so-called nosocomial infections. So this thing is you are trying to prevent, to make sure that you won't transmit among the inmate and also the staff. Yeah. So thank you, Dr. Raja Azim. So for
you again, Prof.
Contributions to this webinar. We hope that you're going to convince the other authority to make sure that how you're going to prevent another cluster outbreak in another detention or any other institutions, because I think this is very important to have policy, how you're going to prevent. Because infections will be here, I think, probably throughout 2021. So we are expecting a few clusters, small clusters, or outbreak will going to happen. So thank you, Doctor. So
welcome.
Yes.
Welcome.
Okay, now we're going to the third panels. Yeah. Let me introduce Dr. Abdul Marsudi Manah. He's the obtained MBBS degree from Universiti Malaya in year 2000s, and also Master of Community Medicine, specialized in epidemiology and biostatistics in 2009. So currently he is the head of the District Health Office of Kudat, Sabah. So he will share to us on the EOC. EOC means that Emergency Operating Center, or in Bahasa Melayu called PKOB, at district levels, and managing confusion of COVID-19 pandemics. Dr. Abdul Marsudi, are you there? Hello, Dr. Abdul Marsudi.
Yeah, Prof.
Yes.
Assalamualaikum.
Okay, please proceed. Thank you.
Assalamualaikum and very good morning to moderator, my fellow panel and audience. Okay, because of COVID-19, we are familiar with the terms of PKOB or Pusat Kawalan Operasi Bencana, previously known as Bilik Gerakan Bencana. Each district has their own specific way of managing COVID-19 activities, so there is no right or wrong in terms of how PKOB should be run. But we must understand the basic concept behind of an EOC. Today, I will share a little bit of my experience in managing and handling the COVID-19 pandemics at the district level. People always ask me how I manage 3 different districts, and each with different color coding. Kudat in red, Pitas in orange zone, Kota Marudu in yellow. First, I have a very good and capable officers at each district. Dr. Nazura and her team in PKD Kudat, Dr. Gauri and her team in PKD Kota Marudu, and Dr. Liana and her team in PKD Pitas. Second, we have a very clear objective instruction, and line of command. Basically, what we did in Kudat was the same in Kota Marudu or Pitas, only with some minor adjustment here and there based on geographical or logistic issue. Before I start, we should go to basic principle of disease transmission. Disease transmission determined by multiple factors such as availability of vectors or human behavior and etc. And because of that, disease transmission is a dynamic process. And because the transmission is dynamic in nature, so disease control also should be dynamic and not rigid. That's why we have different SOP produced by higher authority over time. And that's why we have multiple strategies like MCO, EMCO, or TEMCO. Okay, from this slide, we can see that socioeconomics, human mobility, behavior, occupation played a major part in disease transmission. So when handling COVID-19 pandemic, we should consider all of this. If this is not taken into account, the public will be reluctant to give a cooperation. In managing disease or any other unusual event, each department or agencies in PKOB should always do a surveillance. This is important. Surveillance is a systematic process of collecting a data, do an analysis, disseminate those reports to other relevant agencies so that action can be taken. So now, this is Pejabat Kesihatan Kawasan Kudat located in the northern part of Sabah. There are 3 districts under Kudat Health Office, namely Kudat, Kota Marudu, and Pitas. In each of these districts, there is a PKD led by a medical officer. As of 15 December 2020, Kudat has 70 plus active cases and in red zone, while Kota Marudu in yellow zone with 3 cases and Pitas in orange zone with 39 cases. My presentation today will focus solely on district of Kudat. So we go straight to the topic that I want to share today. My reference for this presentation based on Framework for a Public Health Emergency Operation Center by WHO and Arahan 20 Dasar dan Mekanisme Pengurusan Bencana Negara by MKN. So what is EOC or Emergency Operation Center? EOC is a physical location or visual space in which emergency or disaster management personnel assemble to coordinate operational information and resource for strategic management of public health event, emergency or disaster. Maybe we are not familiar with EOC, but sure we are familiar with PKOB or Pusat Kawalan Operasi Bencana. So the community that runs the PKOB known as JPBD or Jawatan Kuasa Pengurusan Bencana Daerah in the district level and JPBN at the state level. So when implementing an EOC, we should have 3 things in mind. Number 1, what is the objective? What we want to achieve? What is our target? Number 2, what should we do to achieve those objectives, those targets? How every department can contribute? And number 3, what is the structure? What is the line of command? Who should lead? Should we ask kesihatan people everything if there is an issue arise? So in terms of objective setting, in Kudat we set our EOC objectives based on District Risk Reduction Program or DRRP, which was launched by YBTMK on 1st of April 2020. There are different strategies and approach based on number of active cases in district. So if you are in the red zone district, you have different strategy or activities. And if you are in a green zone district, you have also different strategies and different approach and different activities. In terms of function of an EOC, there are 5 main functions. Okay, first is management function. EOC should responsible for an overall operation, including the risk communication aspect, and also in coordinating multiple agencies to work together. EOC also produce and record all administrative records or documents or record keeping, such as instruction letter and SOPs. Second function is planning. Each agency should do their own surveillance based on their capacity and job description. And any findings should be shared among community members or JPPD in EOC. So in planning function, the most important thing is to do surveillance and to share the findings of the surveillance. In Kudat, EOC main agencies in COVID-19 EOC are of course from health office, and then from hospital, police, district council, social and welfare department, BOMBA, and APM or Civil Defence Force. Third function is operation function. This function provides direct response to the incident or to an event. What your agency do to control the COVID-19 spread? How you monitor? What is the advantages? What is the disadvantages? And what are suggestions for improvement? So this is the operation function do. Number 4 is logistic function. In this function, EOC need to acquire, procure, store, track, and maintain availability and readiness material required to control COVID-19 in the district. EOC should have a district inventories. In Kudat, we have district inventories not only for PPEs, disinfectants, but also manpower and vehicles. So if we need an extra man to do public announcement, we have Jabatan Hal Ehwal Agama Islam or Jahins who can help us. If we need extra four-wheel drive vehicle to reach contact house, we have forestry department who can help us. And the last function is finance function. Every district receives a lot of money from a state government to help controlling COVID-19. That money was given to each EOC through district office. And because of that, a district accountant from district office should in charge this finance function and do a proper cash flow management. He should have a dummy board for budget preparation and monitoring and also do procurement. So based on 5 functions of an EOC, this is Kudat COVID-19 EOC structure. So in PKOB or EOC, we should have an incident manager, deputy incident manager, information officer, and 4 sections chief, which are finance section, planning section, logistics section, and operation section. EOC at district should be led by district officer as written in Arahan 20, as state EOC led by State Government Secretary or SKN Setiausaha Kerajaan Negeri for Sabah. Assistant DO act as a deputy incident manager. In the district office, there are 2 assistant DO, which are ADO development and ADO administration. In Kudat, ADO administration is our deputy incident manager. Department of Information Officer will act as a district EOC information officer. Finance section led by district accountant. Logistics section led by an officer from APM. Planning section and operation section led by the head of department from each main agencies. In Kudat, as I told before, the key player in COVID-19 EOC were health department, hospital, police, district council, BOMBA, and social social welfare, and APM. So how EOC could that choose those main agencies, those so-called key players? Because of delegation of work. Health office and hospital cannot act alone in controlling COVID-19 spread. They need support and help. So police department will in charge the enforcement activities and SOP compliance as a general. Whereas District Council in Kudat known as Lembaga Bandaran Kudat or LBK will in charge SOP compliance in commercial or business premises including fish market and wet market. They will close any premises that fail to comply with the SOPs. Whereas Bomba will in charge disinfection activity at the state or federal buildings. Social Welfare Department will manage the quarantine center and food basket assistance program. Hospital will manage the patient and also the PKRC, COVID-19 Treatment and Quarantine Center. And last but not least, the Department of Information or Jabatan Penerangan will take charge the public announcement and community engagement activities. Okay, this is what we do in EOC Kudat. Starting from this slide, I will share pictures of activities that EOC Kudat does. This is the first step. First meeting is very important. We need frequent discussion because so many things we need to iron out. We need to discuss and clear what is the function for each department and how they can contribute controlling COVID-19. What is our line of command? Who should give direction? What is our guidance? What is our incident action plan? What is the current SOP? Our manpower is enough or not? So many things need to be discussed in the early part of EOC implementation. Our EOC also have regular meetings, but not every day. When we entering the red zone, we have meeting twice or sometimes thrice a week, but now once bi-weekly. So this is our meeting agenda. Each main agencies will present the activities and future planning. So APM will present the COVID-19 current situation, number of cases, number of person under home quarantine, number of patients in PKRC or hospital. They also present if there is a public complaint or not, and then the status of district inventories. So the police will present the enforcement activities and the social welfare department will present issues in quarantine center and also the status of food basket assistance program. So that's the example, our meeting agenda. Although our JPBD didn't meet regularly, but our EOC have daily report or daily briefing every day, mostly through WhatsApp group. Sometimes when we have an urgent matter to take care of, usually we will discuss face-to-face or via Zoom with the relevant agency or department. As I mentioned before, we do have a daily report where all departments can see, give comments, and give recommendation. If you're familiar with daily PKOB report, you will notice there is a laporan khas PKOB daerah that DO as an incident manager need to send directly to SKN. This report is such an important report because there is a column for follow-up action to be taken, involves state level decision. Actually, you can plan and inform state EOC early about your planned EMCO. As an example, if you need urgent request for PPAs, if you need additional budget for food basket assistance program, etc., etc., you can write in the laporan khas PKOB daerah. So the state EOC will take notice and plan for you also. So in managing COVID-19 at district level, we need to work together. We need to share the responsibilities and also share the information. In this picture, you can see our police personnel help us a lot in contact tracing, especially in Sabah, tracing the untraceable person. Usually we get help from special branch unit from JSJ, Jabatan Siasatan Jenayah. And here you can see also our MOs with Marine Police on the way to do surveying the Kampung Atas Air, which was inhabited by Palau or Sea Gypsies community. Okay, in terms of training, EOC appoint health office to conduct training, not only to healthcare workers, but also to the non-healthcare workers such as APM, Bomba, District Council, especially on how to don proper PPE and how to do the disinfection. At the same time, we also encourage other agencies to conduct their own eco training to their own staff, but with the health officer supervision. EOC Kudat also engaged the community in a battle with COVID-19. It was organized by APM and Japan or Jabatan Penerangan, as we need help and cooperation from community to do community patrolling and neighborhood watch at their respective village or taman. This is Info on Wheels. Info on Wheels was the initiative of Jabatan Penerangan with the help of police and JPJ. Text and talking point was prepared by PKD, Health Education Unit, and it covers not only signs and symptoms of COVID-19, but also stress management and prevention of dengue outbreak. And the text and the talking points we update regularly based on the current situation. This is a roadblock where police, APM, and Rela personnel working together. We not only have a roadblock in the district border, but we also have a roadblock in a village that have more than 40 active cases at one time. This is enforcement activities done regularly by police with the help of health department, APM and Rela, and also district council. And for your information, at one point of time, we have almost 3,000 plus person under home quarantine order, and we cannot monitor all of them. That's why we delegate that task to the community. We will ask community leader or Rela personnel in that village to monitor person under home quarantine. We call it neighborhood watch. If they see that person breach the home quarantine order, he or she will take a picture and WhatsApp directly to a dedicated handphone in district police office. In this slide, it shows how district council or Lembaga Bandaran Kudat help controlling spread of COVID-19 by monitoring SOP compliance in business premises and market. And they also do the disinfection in fish market. This is our EOC disinfection activities. Premises that have been visited by COVID-19 patient will be disinfected by health personnel. And then Bomba will disinfect state or federal building that need regular disinfect activities. This picture shows how team do contact tracing. We have dedicated sampling team who will do contact tracing and active case detection. Our team not only from CDC unit, but also from other units such as from Bakas, FSQ, and etc. We also get extra help from nursing unit, from assistant medical officer, and from dental unit. Here we can see our enforcement team from UPP, Enforcement and Prosecution Unit from Health Office regularly check and monitor SOP compliance in places that frequently visited by the public, such as grocery stores, private clinics, and markets. Here you can see our enforcement team gives advice to ferry operator that commuting between mainland Kudat and Bangi Island. And also during Sabah state by-election, our EOC also monitor and advise every political party contesting in the by-election regarding the SOP that should be complied with. This is our health team doing mass screening at EMCO localities with the help of police and army. So you can see, without army and without police personnel, we had difficulty in controlling the crowd. This is our team, our sampling team, doing targeted screening in PPR Taman Ehsan Kudat and also to Palau community. This is our health team doing probe screening. We managed to do a lot of targeted screening and probe screening because we got help from other agencies in the EOC such as police, maritime, RELA, APM, etc., etc. We also screen our non-healthcare workers frontliners. They are staff from other agencies who help distribute food basket assistance programs to individuals affected by COVID-19. So before they send the food basket to the respective individuals, we screen them first, make sure they are negative from COVID, and then after that, they can send the food basket. These are the picture of food basket assistance program. All agencies were working together. If they cannot assist with providing a vehicle, they will provide a manpower. As you can see, our bomba also help us in delivering the food basket. And lastly, you can see our district, our EOC district store. It was a multi-purpose hall inside District Federal Building. It was managed by 4 APM officers who works around the clock. Here we store everything, not only food basket, but also PPEs, items for quarantine center such as hygiene kit, blanket, and also items for PKRC such as pillow and etc. That was my last slide. With that, thank you very much.
Thank you, Dr. Marsudi. I think everyone can agree with me with the lack of ideal support and then with the diverse populations, they have done a good job where actually by collaborating with other agencies. You can see here the perspective of EOC, where actually for those postgraduate students, where you become a future public health medicine specialist, this is a very fundamental for you all understand how you can convince the other stakeholder where actually you can execute whatever for the control and also preventive measures. Yeah. So kudos and congratulations to Dr. Marsudi and the team from PKK Kudat. So Dr. Marsudi, so we have few questions here. Maybe I can just allow 2 questions to you. One is about from Syed. What is your advice on how to have a good relationship with cooperation and also collaboration from all these agencies? Please, Doctor.
Assalamualaikum. You can hear me?
Yes, yes.
Boleh dengar?
Yes, yes. Clear.
Yeah. Line not so good in Kudat. Okay,
Yeah.
wait. In term of good collaboration, the basic things first, we need a good communication. That the important thing we need to consider. Yeah. Okay. This is COVID-19. This is our first time handling this type of pandemic. Kan? Semua orang tidak tahu. Kan? So we are the focal point in terms of who should they ask. Yeah. So before we can get a good collaboration from them, can we must to convince them first. But in terms of how we want to convince them, we must have a very good communication with them. So that's why our communication with other agencies is fundamentals in setting the EOC. That's the important thing for me.
Great. I think communications, effective communications, regular engagement with this agency put the trust and headed by DOs and district officer. I think this is the vital thing where actually we can make sure that whatever we discuss or we plan able to execute timely. Yeah. So the second question is about the from Dr. Rohaizat. Prof. Rohaizat mentioned that how you deal with the screening for the immigrants in Kudat.
Okay, immigrant. Okay, there is a two type to answer this question. Okay, if you are kesihatan people, kan? Okay, usually they will ask me how we handle the documented, undocumented immigrant. Kan? Actually, immigrant what's still the same. If you are documented or you are not documented, you are still immigrant, right? So in kesihatan, our activity is still the same. We do risk assessment, we go there, we do swabbing, trace result, and treat if positive. But what I want to discuss here is how we plan and how we execute those plans as an EOC. That's the important thing. So the first one, we need to plan in advance. You remember we have daily reports and daily briefings. Use that. You should use that. And you have your key players. So all relevant authorities need to do their surveillance. Yeah. Surveillance, not only kesihatan people to do it. All other agencies should do their own surveillance. Yeah. Surveillance, as we know, basically gathering info and do an analysis and share those information to other agencies. So that if you share the information, you communicate with the other agencies, then you can do a better collaboration. So in kesihatan, actually we do our surveillance, we deploy our vector, our dengue team, and also our MCH team. Because our dengue team, they have their own GR map, they have a very good data in each of those villages. And our MCH team, they do the personalized care. Yeah, they do the personalized care. They know what's the proportion of children, what is the proportion of adult, kan, pregnant mother. So that one is important. And police also, they do their own surveillance in terms of security. Yeah, in terms of security. Maritime also, usually in Kudat area, the immigrant mostly stay in the kampung atas air. So maritime know the sea route, laluan laut keluar masuk. So they know where to control for the movement of people. And immigration also, we need to involve them because we need to ask them whether they are prepared with the pusat tahanan sementara or not. So all those agencies, we need to engage them. And then also don't forget our logistics section in EOC because they want to know our manpower enough or not, our vehicle, our PPEs. Yeah. And then the keyword here is work together as an EOC or PKOB. And then not only in PKOB, in kesihatan also we need to work together. This is pandemic. This is not a normal outbreak. So we must business unusual. So in PKOB, we must have our structure also. We must have our sampling, dedicated sampling team. We must also have our field investigation team, disinfection team, enforcement team for crowd control. And then our health education team also should go in. They need to sensitize people first. They need to sensitize the community leaders first. Yeah, that's the important thing. And then our nursing, our PPs also need to be involved. Yeah, especially if the localities under that operational area. So, number one is planning. So, if your if your planning is good, regardless they are immigrant or not, so should be no problem. I hope my answer, my statement answered that Professor question.
Okay, great. Thank you.
So usually we go in.
Hello. Yeah. I think. Yeah. Thank you for your answer. I think we can just sum up that from your presentations. You try to highlight the role of EOC will actually become a command center because it's very if you have a structure and then it's quite the functionality is well so frequent in terms of control measures and also preventive measures together with others. I think this is very unique. Those who's working in Sabah. The question about the immigrant, I think in Sabah, immigrant is quite special. They are not really non-Malaysian. They have been here for a long time, more than 20 years. So sometimes they become locals, but they don't have a document. That's why I call undocumented illegal. But anyway, the way you want to tackling this issue, I think we go back to the basics of this thing. Means that interagency collaboration and very clear. I can just sum up for all the three panels. Thank you, Dr. Marsudi.
Yeah, thank you,
Prof. To our own people in Kodat. So they are all our heroes. Thank you, Dr. Marsudi.
Thank you very much.
Okay, so Waalaikumsalam. So for the three presenters, thank you much for your statement or your sharing your experience here. I can just sum up that the important thing is, as a leader, a public health message specialist, the interagencies collaboration, coordination, and also cooperation, that is very important in order for us to combat this COVID-19. Second thing is about the effective leadership is very important because you need to advise the DOs, you need to advise the others, and how you're going to inspire your own subordinate to deliver whatever in the daily task. The third thing is about your planning. It must be a strategic based on the situations. We don't want to be a reactive. I remember that people say why we need to do just screening at any time. By right, we need to analyze. One of the panel mentioned that to do risk analysis, risk assessments, where actually we can do a situation analysis based on the data. Then we can just probably have come out with the control measures. And then not to forget also our own staff about this mental health issue. I think this is very important because we have a few cases of burnout and also the infection and prevention control, not to forget. This is very important. Yeah. And also just now the function of EOC. Yeah, this is very important. Talking about the management, planning, operation, logistics, and finance. So with that, I think thank you very much for your participation today. So maybe whatever we learned today, maybe we can apply for your future practice. So thank you from me as a moderator. I pass to our MC, Prof. Rosita. Thank you very much.
Thank you, Prof. Saffree, and thank you very much once again to all the three speakers for the presentation. And we are glad to inform you that we have 160 participants for today's webinar, even with a short notice. And for the next session, I would like to invite the President of Malaysia Association of Epidemiology to introduce and then to promote MAE to all of you. So please welcome Associate Professor Dr. Rahaizat Hassan. Prof, all yours.
Okay. Assalamualaikum warahmatullahi taala wabarakatuh, and very good afternoon to everyone. First of all, I would like to thank all speakers and participants attending this webinar, and of course supporting out our very first program for the Malaysian Associations of Epidemiology. So on behalf of the Pro-Tem committee members, I would like to present to you the Malaysian Associations of Epidemiology, or also known as MAE. So shall I share the slides a bit on okay. Okay, so we are known as Malaysian Associations of Epidemiology, or Persatuan Epidemiologi Malaysia. Kita ditubuhkan, we were founded in on 29th of November 2019, basically, 2019. But because of pandemic, that most of our activities were postponed. We couldn't proceed with our activities, and our association is registered with the Malaysian ROS. Okay. Basically, what we have, what we aims is basically to gather all the players of epidemiology from different sectors, from different backgrounds, from different levels, to sit together, and this is like a platform for knowledge sharings and human capital developments, so that epidemiology will advance further in Malaysia. Basically, we just need to sit together to come up with something, the way forward, as we are facing new things every moment, every day. Now, not even on the pandemic, but we are facing out on the vaccines, which very much affects our population's immunity and so on and so forth. So basically, this is a kind of promotions to the epidemiology. And to sum up everything, basically, we are focusing more on the lifelong learning in epidemiology. So I would like to invite all of you to join us. Okay, you can join us as a live member, or as ordinary member, or allied member. So everyone can be the members. You can visit our Facebook, FB at Epid Malaysia, or you can visit our websites, epidmalaysia.org. So from there you can see the various types of memberships that we are offering, with all the memberships fees and everything. We are also sharing, I think, in the chat box on our memberships information. So please kindly visit us and join our journey together to develop towards more advanced epidemiology in Malaysia. For any further questions, you can email us to epidmalaysia@gmail.com. So we will try our best to give you further clarifications. So everybody can join us, even the students, you can be an allied members with us, so that in the future, you are the future generations to lead epidemiology in Malaysia. With that, thank you everybody for today's session. It was a great session. To all the speakers, thank you very much. To all the participants, thank you for your support. And let's join us with the journey of Malaysian Associations of Epidemiology. Thank you very much, and Assalamualaikum. Back to Chairperson, Prof. Razita.
Okay, thank you, Prof. Raizat. Thanks again to everybody, and please do join us in our MAE. And you please like our Facebook, MAE Facebook, for further information for our next event. And to remind you all again, in the chat box, we have provided the link to your e-certificate. And lastly, I'd like to thank the technical staff who make this first webinar a happening session. And with this, we have come to an end. Thank you, everybody. Stay safe and hope to see you all again. Bye.
Fine. Thank you very much.